There's a lot that could even go into just the history of how some of the diagnostic things have changed over time, but we're going to focus on looking at the diagnostic criteria, talking about a little bit some of the changes that have occurred over time, and identifying the symptoms specifically that may respond to treatment, because not all of them are likely to respond to treatment, especially medication treatment. And then we'll talk broadly about the medication classes that are used for the treatment of autism spectrum disorder and where they really fit in the grand scheme of things. I am a big fan of primary literature. It was very difficult to try to keep this to the 15-minute timeline, so we're doing broad summary generalizations today. So to get started, the prevalence and risk factors for autism spectrum disorder, the most recent estimates from 2016 are actually that 1 in 36 children are diagnosed with autism spectrum disorders. In 2000, it was 1 in about 110. In 2006, it was 1 in 88. In 2012, it was 1 in 68. And in 2016, it's gone to 1 in 36. So they've seen a significant increase in the number of individuals who've been diagnosed with autism spectrum disorder. There was some original discussion that maybe it was because the criteria were really broad and varied, but that doesn't look to be able to explain the sustained increase in diagnosis that we're getting over time. So some risk factors for developing autism spectrum disorder. So genetics appear to play a role. There are a number of different genes that are being explored. There's not one in particular that's been identified. For identical twins, what they found is the rate of diagnosis of autism spectrum disorder in the twin ranges anywhere from about a third, so about 33%, up to 95%. So that seems to support that there's a relatively strong correlation. Interestingly, when you just look at siblings, so non-identical twins or just plain siblings, it's actually much lower. The siblings prevalence is 2 to 8% higher risk than the general population. So there does seem to be a genetic variable, but there may also be some environmental factors, specifically during gestation, that may put these individuals at a higher risk. And that might explain the discrepancy between the prevalence in twins versus just the plain siblings. Kids who are, whose parents have a psychiatric disorder are at a higher risk. Any preterm birth, so prior to 33 weeks, or lower weight on delivery, they seem to be risk factors for autism spectrum disorder. And then fetal exposure to psychotropic medications or insecticides. So there are a lot of exploratory trials going on to look at general exposure. They're looking at environmental exposure, food exposure to different chemicals, as well as medications. The psychotropic medication one was really targeted initially, and that seemed to partner with parental psychiatric disorders. So thinking that if a mom had depression and was on an antidepressant, that increased the risk for the child. But what they're finding is they're actually individual risk factors. So the medication exposure, the mental illness itself, and potentially some other factors go into increasing that risk. We're going to look in the next few slides at the different symptoms, the diagnostic criteria for autism spectrum disorder, but I want you to keep in mind these 3 buckets. So social, behavior, and communication and language. These are going to be the 3 main target areas that we're going to explore with both the symptoms as well as with treatment. So diagnostically, there are 2 main sets of criteria, and then kind of make sure it's not due to something else. The first one is related to social communication and social interaction. So patients with autism spectrum disorder need to have persistent deficits in a bunch of different communication standpoints. So social and emotional reciprocity. So individuals may not be able to respond to emotional cues. They may lack facial expression. They may have a difficult time with nonverbal body language and nonverbal communication. I have a great example. I have two children. My daughter is 10, and she is very challenging sometimes, and I wonder about her ability to navigate the social emotional balance sometimes. But I got some bad news yesterday, and I was pretty upset. She came out of dance and was talking, and I hadn't said anything. I was just letting her go, and there was a song on the radio, and she was waiting for the part that I usually sing because she was singing along. And the fact that I didn't then clued her in, she looked at me and then was evaluating nonverbals. I still didn't say anything. And she was able to really respond to, hey, there's a problem here, even though nothing's been said and there's nothing obvious. And she turned off the radio and said, all right, what's going on? So being able to identify some of those things that are really not obvious could be noted early in development. So even in toddlers who are unable to see some nonverbal communications or have difficulty expressing their emotions for peers. Other areas that there could be deficiencies are deficits in nonverbal communication that could be problematic for social interaction. So expressing distress or anxiety about a situation, especially in some of the younger children, that then a parent would be able to respond to. They may not be able to give those warning signs before they then act out. And deficits in developing, maintaining, and understanding relationships. So this could be relationships with peers. It could be relationships with their family members, including their parents or their caregivers. So they may not necessarily develop that type of a reciprocal relationship where their association with a mother, father, or caregiver may be more functional or operational. That's the person who delivers food, that's the person who provides clothing, and not necessarily a more developed relationship. And they may have a lot of difficulty relating to their peers and making friends in general. So the social communication piece is a big barrier. And then there's also some behavioral pieces that are also diagnostic. So this is one of the areas that has changed with the DSM-5. So the number of different restricted repetitive patterns of behavior, interest, or activities, they lowered the threshold, so only 2 of these are required. The thought was maybe that made a much bigger category, but in looking at these, it seems to capture the vast majority of patients who would have been diagnosed under the DSM-4 as well. So there was a 91% concordance with, if you were diagnosed under the DSM-4, you fit the DSM-5 criteria. So even though that changed, it doesn't seem to be opening up the floodgates or restricting it too much. So these activities that tend to be problematic are really going to be the focus of our drug treatment. Looking at stereotyped or repetitive motor movements. So this could be things like hand flapping or rocking. Some individuals will may potentially have arm movements. They may be biting or gnawing on different parts of their body. Some individuals actually have self-injurious behavior that's their repetitive movement that could be problematic. I had a patient in a pediatric nursing home when I worked in New York who her repetitive behavior was a head rock. And she was allowed to do it, but she would sometimes rock much more aggressively. So they actually gave her a rocking chair. Unfortunately, there were folks that weren't paying as close attention as maybe we would have liked. And she was rocking and slamming her head into the wall. And actually was able to detach both of her retinas from the trauma of that. So it really could become quite excessive. And she still wanted to rock, so that really could become problematic for her. So they could be minor and not interfere, or relatively major and have some massive complications. They may also have some repetitive use of objects or speech. So they may repeat back things or really get stuck on certain noises or sounds. And they may also be relatively obsessed with certain, how they use certain objects. There is a pretty consistent insistence on sameness. So they're very inflexible to changing routines. They have patterns that are ritualistic that may look very similar to an obsessive compulsive type behavior. And that could be in verbal or nonverbal behavior. So it may be in the way someone greets someone else, if there are certain things that they feel that they need to say. We had one patient who was maybe 6 or 7, and the way that he would introduce himself was he needed to say, hello, how are you? My name is, he would say his name, and then he would say his age, and then he would say the reason that he was here. I am here for, but if you interrupted any part of that, you then had to start over. So it was really important to kind of give him space because he needed that whole thing to go smoothly, all of the sentences all in one chunk. Otherwise, he was unable to get past the introduction piece to even talk about anything else. There are also some highly restricted fixated interests. They can be abnormal in intensity or focus. In some instances, this may be beneficial. So for some individuals, this may actually be what their life calling turns into. We had a patient who worked for the railroad, was absolutely obsessed with trains and knew more about locomotives than I thought ever existed. It was fascinating to have him come in to tell you about that, and he had been obsessed since the time he was about 2, but had been able to utilize that obsession very well. It was all he was interested in, all he wanted to do, and he was able to be very successful with a career. Sometimes those interests could be in other things or bits and pieces. We had a number of patients that would take apart toys because they were really fixated in gears or springs or little parts of that, which could be really destructive. We had one patient who was able to very quickly deconstruct one of the mini refrigerators, which was a little problematic because they were a number of them that were taken apart. And they were very difficult to put back together. So in some instances, that could be really problematic. The other piece is hyper or hyporeactivity to sensory input. I think traditionally a number of patients with autism spectrum disorder are thought to be overly sensitive to sensory input, bright lights, loud sounds, sometimes strong smells. But there are some individuals who may have a reactivity to touch input that may actually be beneficial for them, where they are looking and seeking out that type of sensory input. So it can go in both directions. This is really the set of symptoms where we're going to target the pharmacotherapy. With the social communication, we'll see a little bit of efficacy there, but these would really be the ones that are target symptoms for that. The last bucket for diagnostic criteria is the symptoms must be present in early developmental period. One of the main points that they make related to this is humans are incredibly adaptive. So even though some of these could be problematic, we may be able to develop coping strategies that make them less apparent. So if they are present, we want to capture them early to help get treatment so that the patient doesn't have to develop coping strategies alone, but that we could utilize some other treatment options for them. The symptoms are clinically significant, cause clinically significant impairment in social, occupational, or other areas of functioning. And the disturbances are not better explained by something else. So this one, the disturbances can't be better explained by intellectual disability. That doesn't mean that intellectual disability and autism spectrum disorder can't occur together. They can. It's just that these behaviors should not be directly from the intellectual disability or developmental delay. One other thing that helps cloud the picture sometimes are the comorbidities that we see with autism spectrum disorder. So there are a large number of psychiatric comorbidities that coincide. So anxiety disorder, ADHD, bipolar disorder, and depression. These can be difficult to determine if a patient is depressed or just socially withdrawn, and it's part of their communication deficit. So something to keep in the back of your mind that sometimes it may not be from the autism spectrum disorder itself, it may be a co-occurring other disease state. The attention deficit hyperactivity disorder is another good example, especially with some of the impulsivity that we'll see in some of these patients. So if we're exploring treatments for that, we may want to think maybe this is ADHD itself and kind of challenge that thinking. So stimulants are actually one of the drugs we're going to cover. So our treatment options, I started with the non-pharmacologic treatments. So there are quite a few things that have been suggested as non-pharmacologic treatments for autism spectrum disorders. One thing I want to make very clear is there is no, if there is minimal risk, a lot of times patients and families will explore any potential option. I think it's really helpful to identify what symptoms are the most problematic to try to understand what the families are trying to go after, what they're looking for benefit with. If they're looking to change it overall, that may be unrealistic expectations. So helping them align, here are the symptoms we're trying to reduce or improve their functionality, here might be some options they can look at. So complementary and integrative health, there are a large number of trials and things that have been experimented with. These are just some of the ones that have a little bit better data. Some patients have had some benefit with acupuncture. In some cases, it's helped with communication. Usually it's with impulsivity, some of the social withdrawal, as well as impulsivity, agitation, and some of the social withdrawal. There's some data, it tends to be mixed. There are patients who are hyper responsive to sensory input, and this would not be a good fit for them, where there have been some reports of patients having a little bit more trouble tolerating it than we would expect. There are a number of auditory and sensory integration practices, so utilizing occupational therapy in a number of different formats, and doing it throughout the day in a number of different settings to try to allow the patient to be more accepting of some of the sensory inputs, and tolerant, so they would be able to go potentially from a home setting that's more quiet out into more of a public setting where there may be more motion or more noise around, but allowing them to do that a little bit smoother and less distress. Massage can be helpful for some patients. That's similar to yoga. If there are some repetitive movements or muscle movements, there might be either positions or stretches, things, physical manipulation that could be helpful and seen as relaxing for the patient. That would be really helpful to know, especially if a patient gets very anxious when they go to different places or if their schedule is disrupted. If there are minimally invasive excuse me, massage techniques that could be used, that may be a huge benefit to the family to be able to make have this patient not be in distress if they're stuck in another doctor's office where they need to wait. We had a patient who was having some gastrointestinal issues and was sent to a specialist, and the office of the specialist was running more than 45 minutes behind. And that really became a challenge for the patient who was out of their routine in general. And then when the staff member who was with the patient had inquired about how much longer would it be, there was a little bit of a verbal exchange that got heated. And because of the yelling, the patient got very, very agitated and took their kiosk, so those little informational displays, it had a computer on it that was playing a video, took it out and threw it across their waiting room, which then they obviously asked them to leave. They didn't want them back. But that became very challenging because then trying to find a specialist that was willing to accommodate when the patient had been deemed threatening and really aggressive, when it may not have been all just due to the patient. There were a lot of circumstances around that. So sometimes if there's those techniques, it can make unintended obstacles much more easy to deal with for the family and the patient. The other thing that I thought was interesting that I didn't know much about, and I will admit I didn't look into tremendous amounts of detail, but music therapy. So there have been a number of interventions of music therapy with patients with autism spectrum disorder, encouraging their social interaction, their communication, as well as helping with some of the agitation and anxiety that they have. So they actually were starting to see some benefit in the social engagement aspects of autism spectrum disorder, and not just with the anxiety and agitation. So that's an interesting area. Some of the other treatments, cognitive behavioral therapy, social behavioral therapy. So those tend to be a little bit more standard for patients that are more responsive. And then there are a number of potential interventions related to supplements and dietary changes. I will admit my bias ahead of time. I'm very skeptical of extreme diets for this particular patient population. The reason for that is that the patients can become very rigid and regimented in what they are willing to eat or not eat. So we had a couple patients who would only eat things that were white. One, it was white, one, it was green. The green one was a little bit easier to ensure that they got a balanced diet. The patient who would only eat white things, that was a little bit more challenging to try to make sure that nutritionally they were getting everything that they needed. So we actually had a pharmacy that would compound some of their medicine, in particular capsules, because the patient wouldn't take any pills that weren't white. So sometimes I think that could be a little bit challenging. So if families want to go that route, I strongly encourage that they engage nutrition. So they get some dietary assistance to make sure that especially the kids are getting everything that they need. The gluten-free and ketogenic diets, there are some reports that these have been beneficial. Most of those are based on subjective reports from the family. In some of the clinical trials that have been done, there's inconsistent results. So it is an option, especially if the family sees a correlation, but there is not consistent data to say that that's beneficial for helping any of the symptoms of autism spectrum disorder. There are some trials looking at the use of omega-3 fatty acids. There looks to be a little bit of data, but that is also inconsistent, which may be a result of a lot of the formulations of omega-3s aren't always standardized, but it has been shown to potentially be beneficial with some communication interaction as well as some agitation. So maybe is an option, but probably not going to be a standalone at this point. So lots of things that people could do supplementally. I bring up the non-pharmacologic treatments first. More than 75% of families that have a child with autism spectrum disorder seek out complementary alternative therapies. So even though they may not tell you, they may be looking for something else. So it would be something good to ask about, and especially explore other options, because the side effects of the medicines that we could use can be scary, especially using them in children. So we're going to focus on 4 particular drug classes, more because of the sake of time. There are others that are used, but these really have the best data. I did them alphabetically. So don't take into account that I'm saying clonidine and guanfacine or alpha-2 agonists need to be first line. It's just they come first alphabetically. These agents have been found to provide benefit for aggressive behavior, anxiety, and definitely sleep disturbances. So they tend to be well tolerated. It will cause some drowsiness, potentially some constipation and dry mouth, as well as some dizziness. So they can lower the blood pressure and make patients dizzy. There have not been reports of major tolerability concerns in any of the trials that have been done, recognizing most of them have relatively small numbers of patients included. But where they've seen this best is in patients who don't sleep, who may have some aggressive behaviors and they have a difficult time getting them to wind down and go to sleep. So that tends to be one of the main areas that this is used. It's been found to be beneficial in getting patients to sleep faster and keeping them asleep, not so much for individuals who wake up really early in the morning. That data hasn't been, it's not quite as strong as getting patients to sleep. So those are both options, immediate release as well as the extended release products. And it's interesting that those have been found to have some efficacy with anxiety. In our antidepressants, the SSRIs tend to be the class that's used most commonly. First line for anxiety, these really don't have great data for the treatment of the anxiety symptoms in autism spectrum disorders. The main area they have consistent data helping with is repetitive behaviors. So it might be the rocking, the hand flapping, any type of repetitive ritual that they may go through. We had one patient who was an adult who his ritual was he would be introduced to you, but then he needed to see your socks, which was a little intrusive to people who didn't know him, but that was his behavior. It was fine once you knew that was going to happen. I actually had students that would wear crazy socks for him when he would come in, but sometimes the ritualized behavior could be problematic, especially if they're out in public. So the antidepressants, the SSRIs, seem to have the best data for assisting with the repetitive behaviors. None of the trials really show that it makes them go away completely, but it may make them less intrusive, and there may be less amount of time that the patient spends engaged in the repetitive behavior. Of the SSRIs, sertraline has the best consistent efficacy. It has a little bit of effect for agitation and aggression, but mainly for those repetitive behaviors. Data for citalopram showed, in one trial, it showed that there was benefit for agitation, repetitive behaviors, and anxiety, but in one of the larger controlled trials, it did not differ from placebo. So it's not really clear if there is a benefit from the citalopram. The S-citalopram, interestingly, related to citalopram, but had many more tolerability issues. So patients really seem to have a hard time staying on this medicine because of some agitation and aggression when they started it. Fluoxetine and fluvoxamine also have been used in this patient population, but again, inconsistent results. In some reports, there has been benefit for repetitive behaviors, but other times they have not seen any difference. I would highly recommend making sure that we have a clear idea of how frequently and how severe the behaviors are initially. There are some reports that the SSRIs can actually make those repetitive behaviors or irritability and agitation worse. So knowing where they are at baseline so we can compare to that once they start on this medication is vitally important. And if, unfortunately, when we look at a lot of the notes in the chart, it's not clear where the patient was. So now we've started a medicine, and did it help? Did it hurt? Now we don't know what to do with it because we're unable to make that determination. So clear documentation of that can be helpful. The antipsychotic medication. So this is one of the medication classes that has a major concern, and it's related to the long-term side effects. So it's the class that has two agents that have FDA approval. So the risperidone and aripiprazole are approved for the aggression and irritability behaviors associated with autism spectrum disorder. They both have relatively robust clinical support that, yes, they make that better. Interestingly, risperidone doses were low. On average, they were just under 2 milligrams in the patients between 5 and 17 years old. And they did see an improvement in those repetitive behaviors and aggression. That one was relatively well tolerated. The aripiprazole, the trials for that, the average doses were under 10, so about 8 to 9 milligrams. They actually saw more adverse effects, so more irritability and agitation. There was some drooling and tremor also with some of those. I bring that to your attention because with the aripiprazole, it would be helpful to go slowly. So start with low doses, 2.5 milligrams or less, and really make sure the patient can tolerate it before we escalate that dose. The reason being, if the patient has aggression that's severe enough that we need to provide a medicine for it, aripiprazole can be activating. We don't want to necessarily make that worse because that may put the patient in danger, that may put the family or caregivers in danger. So we really want to make sure we're conservative with the aripiprazole and we move that one slowly. Other antipsychotics, you will see many of them used. Ziprasidone and olanzapine are the only two that have some efficacy data to support their use. The ziprasidone actually has interesting data. It's beneficial for repetitive and aggressive behaviors. It also can be used if a patient's on another antipsychotic and switches to ziprasidone. So in that trial, they had patients who had responded but gained weight. They moved them to ziprasidone and the efficacy was maintained, but the patients actually lost weight. So that's where we would see a lot of these second line options. So it's helpful that that actually has some evidence to support its use in that arena. The olanzapine was beneficial in most trials, but there are some significant concerns related to weight gain. So this one really tends to be relegated a little bit later in the treatment algorithm because we don't want the patients gaining weight. If they are on these medicines, we do need to monitor lipid levels as well as glucose levels. So in children who have autism spectrum disorder, having to get a blood draw can be very challenging. But we also then don't want them having out of control blood sugar values for an extended period of time. So it's a very delicate balance trying to navigate the efficacy. So make sure this is actually helping because the side effect profile can be very significant with these. We don't see as many movement disorders, so tremors, rigidity, any type of the dyskinesias, so tics or twitching in the face. They don't seem to happen as often in autism spectrum disorder patients as what we see in patients who may be using these agents for other reasons. So because of oppositional defiant disorder, they have refractory depression, bipolar disorder, but they are still a concern. So these you'll see used quite often. There's not good evidence to support or to provide guidance on how long, what the duration of therapy needs to be. So re-evaluating, are aggressive symptoms still a problem? Could we look at reducing the dose and getting rid of this is essentially important because sometimes these get added on and just get continued without really having a clear understanding of, yes, it's a benefit, recognizing the side effect burden that can come along with it. And it does influence sex hormones. So for children in particular, that may cause some logistical concerns as they're supposed to be going through puberty. And it can lower those sex hormone levels in general. The last class we're going to look at are the stimulants. So these are also used very commonly, and it's targeting symptoms of hyperactivity and impulsivity. It's interesting because some trials say that it can help with irritability, but irritability tends to be one of the common adverse effects that we see associated with both the amphetamine salts and with methylphenidate. So the recommendation is to start with low doses to ensure the patient can tolerate it and then escalate the dose. Likely it will be lower doses than what we target with ADHD, but specifically it may help with the hyperactivity and impulsivity from the autism spectrum disorder. We do need to monitor cardiovascular, so heart rate, blood pressure, but overall they were relatively well tolerated. So I recognize that was a very quick 30,000 foot view of treatment of autism, but I wanted to give some parameters around why might we be using some of these agents. What I hope you take home is that we need to know what the target symptoms are. Sometimes these kids have really long medication lists and we're not sure what we're doing. Why was this started? I didn't start it. Nobody wants to stop it because we don't know what it's there for. So knowing what we're trying to treat and what's there to treat that will really help clarify that. And then going back to reevaluate, I would challenge all of us that we need to look at the med list and make sure, is what's on board actually necessary? Could we look at maybe getting rid of it? Because adverse effects could be a problem initially, and especially with the antipsychotics, it could be a problem long term. So we want to be mindful that this individual is growing and changing, and what we have been using may not always continue to be the best fit for them. I think that's all I have.
Thank you, Sarah. And autism is definitely one of those topics that I feel like highlights the importance of a very well